Okay, we are
Hi,
ready
Mohammed.
for the last case for you guys. This is a 75-year-old female who was found to have a 45 millimeter non-granular lateral spreading tumor in the cecum during a routine screening colonoscopy. The biopsy of this polyp was positive for a tubular adenoma without any high-grade dysplasia features. The patient is here today for an underwater colon EMR.
Good morning.
Hi, so good morning, almost noon.
Oh, it
I
is.
have
It's good afternoon.
taken special effort to clean out this colon because I know we're getting close to lunchtime and I wanted to make it really as clean as possible. And that's possible using what I call global water exchange. So I turn off the gas and I basically keep my foot on the irrigation pedal. So I am infusing water while simultaneously aspirating. So it's a total exchange with a net zero, almost net zero remnant of water in the colon, because whatever I pour in, I pull out. And I am now parked in the terminal ileum. It's my favorite spot, and it's a great spot to underscore the advantages of underwater endoscopy. Now, underwater endoscopy, 10 years ago even, it was a novelty. And I was using it for EMR, which I'm going to show you. But now you're seeing underwater milieu as becoming very popular for other procedures. So we're seeing underwater ESD, underwater POEM. So we're seeing a lot of procedures that are taking advantage of this different medium for evaluating the GI tract. And so now in the terminal ileum, we are looking at these marvelous villi. And you can appreciate the floating effect. So what you get underwater is that three-dimensional floating effect and that buoyancy. And we take advantage of that floating effect when we do the resection. Now, the wall retains its native consistency. The wall layers stay consistent. And I discovered, now it'd be 15 years ago, that underwater, the mucosa and the submucosa involute, but the muscularis propria stays round and like a frame on the outside. So again, just to emphasize the optics here. So water is also a wonderful medium to interrogate. So you can see how we can move these villi around like this. And that gives us additional information about the tissue. So this is, of course, all very normal. Now we have that 1.33 magnification effect of water, and I'm on near focus, which is one of the reasons why I use the adult colonoscope, because it does have the near focus, which we don't have yet, at least with the pediatric. But I also like the larger channel. This is a 3.7 millimeter channel. And now this is the latest generation from Olympus. It's the Easy 1500 DL. And so we get some additional bells and whistles. And you can see here, if I press on this, we have NBI, beautiful. So here we can see the vascular pattern better. And then if I press again, RDI. So this is if you have some bleeding. You saw this demonstrated by Dennis earlier. So this can help identify a bleeding source or point to where the bleeding is coming from. And then finally, I think we have the last one, which would be TXI. One moment, let's get this off. And this one is TXI. So it just gives you a different contrast enhancement. So these are all additional optical bells and whistles that we have to enhance the imaging even further. All right, so now let's move on forward now that I've sort of demonstrated the, I think, the optical advantages.
Dr. Binmoeller, we are going to just switch rooms for 1 second and we'll be right back with you.
All right, good.
Although we still see you, so don't say anything off camera.
So I'm just pulling back. I can actually get really far up into the ilium with the underwater technique. It's like floating the boat upstream. So this is a very useful technique for also deep intubation of the ilium. I want you to just look, if I'm still online, I think I am. Look, the IC valve is facing me here, right? So it's easy to intubate the ilium. It's just floating, and there's a lot of fat, of course, in the IC valve. Here's the cecum, and I guess I'll just continue for now. And here's our lesion. Now, I think this was full of seeds and debris. There still is a lot of debris in here. So I'm going to irrigate this a little bit more. The other reason why I like to go into the terminal ilium is to clear out debris that afterwards may flow out and then sort of contaminate your view, your vision, and so forth.
Okay.
Is the gas off?
We are going to let you clean out that debris, and we will be right back in a second.
Good. I'll do a little clean.
We are back with you.
Good. So I'm still cleaning up, but it's getting better. There are a lot of seeds and residue. You can see some of that here. I'm trying to remove as much of this as I can. So I think this is actually emanating from the AO. I think the AO is right here. Question is whether it is extending into the AO. That's possible. Here's, I think, the rim of the AO, and it's hard for me to tell whether it is extending into it, but we'll see after it's removed. All right, so I'm going to now insert a 33 millimeter Captivator 2 snare. It's the largest snare that I know of that's on the market. And I'm going to start with making some diathermic dots around the perimeter. Now, it's not essential to do that for these villous lesions like this. For SSAs, I do routinely always make some diathermic dots because it can be difficult. It's very subtle, the transition between normal mucosa and the abnormal serrated mucosa, the lesion.
Dr.
So
Binmoeller,
I'd like to
what
just
settings?
demonstrate how I do this, because I think making these dots is a nice way of just confirming afterwards that you have resected the entire lesion completely. So complete resection means that there is no visible lesion left endoscopically. The R0 resection, of course, depends on the surgical pathology. So the way we make our dots is Ray here is going to advance, and Ray's to my left here, advance the tip out a little bit. And now she's going to recess it, mean pull it back so that you can barely see it. Now you need to be on white light for this. You can look a little through the catheter. So pull back a little bit more, Ray, a little bit more, stop. All right, now it's recessed. And the advantage here is that I can make my dots, but I'm not risking that I'm going to create a perforation or a hole in the wall. And I'm underwater, so I should be able to get some really nice crisp dots. I'm going to ask Jazz, and I'm going to tell her to step on the water pedal when I need it, because my foot now is going to step on the blue pedal, and we're on soft coag. Is that correct for the dots? Yeah, very good. So just to demonstrate how it's done, Jazz, if you could just be a little bit for a moment. So I just step like that. See that dot? Nice and crisp and round. And then I'll go like this and then go here. And I'm just going along the perimeter. And once you're in the groove, Jazz, a little bit, please, because the water is distending for me. And then I'm torquing with the shaft just to sort of see where I think sometimes it's a little blind. I'm just on the edge like that. Okay. And then I can go over to this side. And what I'm doing is I'm using the cap. Okay, Jazz, a little bit. Okay, good. I'm just going to pull back a little bit and flush more. We got a lot of debris here, some more debris. Okay, I'll go there. I'll go there. And just sort of remember, I'm not doing ESD now, right? So I don't have to be so precise in terms of where exactly those dots are. I'm going to end up, when I do the resection, I'm going to be turning around. So maneuver your scope and then use the water to float it up a little bit. You use your catheter to lift like this. Okay. And so sometimes you may not see exactly where that transition is, but you lifted it up and then you just go down and then make your dot. So when you lift up again, you'll see your dot. All right. So you can go here. So this is how we make marking. Now, if I made the dot there, it would actually be far away. So I got to pull back and jazz a little bit more. This is saline, by the way, because we call it, it's under saline technically, but the ocean is saline too, and we call it water. Now there, I think maybe the tip of the snare may have fallen back a little bit. Good. That's enough of this just for demonstration. Now I make good use of my team. So I have Ray here to my left, and I have Leanne right over here. So Leanne, your job is going to be to hold the scope here, the shaft, So good. So now my settings. So let me just kind of go through the steps right now. I'm going to open the snare all the way. I'm going to let that buoyancy effect, that floating effect, allow the lesion to rise up into the snare lumen. I'm going to press down flat, and then we're going to close the snare. And I'm just going to hold it there for a moment while it's closed. I'm going to look for I'm just going through the steps for the discoloration. And then when I feel comfortable, then we're going to resect. And when I press on the yellow pedal, that's auto cut I'm using, right? Settings for auto cut 1.6. Then you're going to wait for the two B's. And that's bubbles. You're going to look for bubbles and blanching some whitening. And then you're going to cut through. And, I've got enough to do with my hands that I rely on you to close the snare for me and cut through. All right. And then I'm going to take back the water pedal myself. So I have control of that. The water is giving me the heat sink effect, which I also want to take advantage of. Let's open the snare. All right. Now this lesion, by the way, it doesn't look like 4.5. It was 4.5 in the description. And if I put gas in and distend, this thing will flatten out and it will be 4.5. But it fits in a 33 millimeter snare because it's contracted, right? So I'm taking advantage of that contraction of the lumen and that floating effect to be able to maximize the amount of tissue I can get on block. And now it's just a question of my jiggling a little bit and getting that snare to the right side needs to come down, right? So these snares are not that torqueable. So I'm going to have to adjust myself, and I do a lot of jiggling. So I know where the tip of my snare was, right? Because one of the problems is that sometimes it'll flip up. So I want to make sure that that tip is as flat as possible. All right. And then there's no harm when you feel like you're in a good spot, just close the snare, so start ready to close the snare. And I'm pushing in, I'm using what I call torque and crimp effect. Now I don't have to go over these two folds, right? So maybe I'll come a little bit closer. There's no reason, we want clear margins, but we don't have to be excessive. We just want it outside the dots, right? So I'm going to hold this. Leanne, you're doing great. And just kind of hold that right there. Okay, I think it's floating nicely. And then I might do a little water pull just to contract it a little bit more, but it's gentle. It's a gentle water pull, right? With gas, you'll suck in the whole wall. And this is just a gentle water pull. So it's just slowly contracting, pulling out some of the water. Of course, you're distending with the water. So, and then when I feel like I've got the right point, now Ray, start to close, please. Close, 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 close. Now, Ray, I want you just to hold that. Just hold it closed. And now I'm going to pull away and I'm going to take a look at what I've captured. And I'm doing the French rotisserie. So I'm just moving like this, trying to see, do I see those dots on the side like that? Look at that. Maybe take the ear focus off for a moment so you can see more in the distance. Looks good on the left. Go to here to the right. Looks good. See the dots? So those dots are helpful for that. All right. And then you can sort of maneuver back and forth a little bit like this. I think it's good. So now, Ray, we're going to wait for the two B's, all right? Remember what they stand for? Bubbles and blanching. All right, good. So you're going to wait. You're not going to close. You're just going to hold this. And oh, by the way, the discoloration is the other thing I look for. Looks pretty good. And you see how it's red there. So that's all good. All right. So these are all things that my team, they know about. And we just go through that checklist. Okay, good. Let's go. All right. Blanching. We see some bubbles. Go for it. Start cutting through. Cut. Good. Go all the way through. You're all the way through. Now, when there's more resistance, it's possible that there's a little perf. We'll have to see. So let me look. Now, right now, the gas is off. All right. And I'm going to look, as long as you're underwater. Look, the body is 80% water after all. We're fine. I don't want to put any gas in there. So let's just slowly turn and look and see what we have. There's the margin. There's the margin. There's the muscle. There's the margin. Remember, it's a small footprint, right? Because I contracted everything. So I'm just using my water to distend enough to see the margins. Now, there's some residual here. That's okay. I'll get that. And we'll use a smaller snare. So that's the backside that I didn't get completely. I call this trimming. All right, so let's take this 33 out and give me a 20.
I wonder if appendiceal orifice. Sorry, go ahead.
Yeah, we'll see. I thought it was, I think it's there.
Yeah.
I think this is the part that goes into the AO.
I think that's why your snare probably slipped off at the end.
Correct.
Because of the
Yes.
indentation in the AO.
Yeah. So now we need a smaller snare. And this I'm going to suck in. We'll go on near focus. Going to suck in. By the way, you know, in our report, we have to say, what was the Paris classification? And this was a 1S, 2A. So it had a polypoid part. That's the S, right? And it had a non-polypoid laterally spreading part. That's the 2A. And the Kudo pit pattern, I don't know if you saw that, you saw branching, right? So that automatically makes it a 4. So 3L are just the tubes, tubular structure. And when you see some branching, it's already a 4. And I did not see anything that suggests a 5 or invasive cancer. Okay, now let's wait till we have. And the nice thing is I have no bleeding, right? So that's good for now. And I can show you if you do have bleeding, you use the same technique. Just advance the tip out, pull it and recess it, and use the tip of the catheter with recessed snare to do your coagulation.
Dr.
All right,
Binmoeller,
Leanne, you're
this has
on
been
now.
a
You're gonna
really
hold my
excellent
scope for me?
demonstration. Thank you so much.
You don't want to see this part of the AO?
We
Come
have,
on.
we of course really do want to see it. We're gonna
This is the fun part. Look, the other stuff was
okay,
just
okay. The
sort of
audience wants to see it.
open.
Let's
Open. All right, so now this is really where the crimping is so important and torquing and getting, see, that's where the AO is. So now I just have to maneuver it. I'm going to definitely do some water pull, doing the jiggle maneuver. You can see that's the AO there, okay?
Yep.
So we need to scoop this out of the AO, the appendix, and press down. And I'm using now, by pushing in, it helps invert that portion that's in the AO, right? Pushing the scope in does that a little bit. And the water pull helps, okay? So just hold this. Thank you, Leanne. All right, now I'm gonna hold this like this, close. It's okay, it's sucked up, but it's all right. Look, this is fat. This is fat in the submucosa, right? So it's fine. This is good fat. All right. See, there's good fat and bad fat. This is good fat. All right. And you look at the vessels in the fat. Just to emphasize, when you're cutting into the fat tissue itself, you get a lot of bleeding. Okay, are you ready for the 2Bs? All right.
Do you remember what the 2Bs are?
Okay. Good. Cut through. Go for it. Cut. You're all the way, but it hasn't cut through. There it is. All right. Now, same thing. Let's look. There's the AO. There's something at the rim, though. Still a little bit of trimming I probably have to do. There's a little bit left here. Okay.
Actually, that's in the appendiceal orifice. That one.
It could be.
Yeah.
It could be.
I think so.
I know. Yes. Yes. So good. Now I'm going to switch to a smaller snare. Now you can give me. Just give me a 15. You really have to pick. You have to have. Look, snares are not expensive compared to what ESD costs and some of these other procedures we do. So it's going in right now. This one, I was debating 10 or 15, but I'll go with the 15 because I really am going to have to pull this in pretty strong. So what I did is I got everything along the rim. Now this is a sign that this is probably going deep into the appendix.
Is it worth
And
trying
she's-
to lift
What?
here?
But she'll just need an appendectomy after this, right? We're still gonna save the ileocecal valve. That's the most important.
What about
Would
an
you
That
consider
marvelous
STRD?
valve, that is a one-way valve. The colon is full of microbiome, and the small intestine is sterile.
Dr. Binmoeller, what about would you ever consider doing a full thickness resection with a dedicated FDR device?
No, after I had several patients that came back with horrible appendicitis, I stopped. Open.
But does the patient have this one?
Well, that's a good point. If this patient, as far as I know, did not have an appendectomy, but if they had an appendectomy, I think it's fine.
Right. Yes.
Now, of course, you got to pull the whole scope out. What you didn't see is she has bad diverticulosis.
Ah, I see.
And so you'll have a challenge getting that cap, through the.
Good point.
Dr. Binmoeller, at the expense of potentially getting booed here in the
Oh, this-
room, we are going to keep your video alive, but we are
You're
going
going to miss the best
I-
part. Yeah.
we will continue to watch this, but we do have to quickly go to another room.
But he got it.
And-
Looks like he almost got it.
Okay, we'll do
All
a
right,
countdown,
okay.
like 5,
Just cut
4,
it through this time.
B and B.
Cut through.
B&B.
All right. Thanks.
We are back with you, Dr. Binmoeller.
Good. All right. So I'm just here in the AO now, and I'm going to see if I can. But you know what? It's very acceptable. This is to also get this with hot avulsion technique or just biopsy it really. So I've got a 10 snare now. So I've used up probably their year's supply of snares. Let's see. Let me see if I can just get this a little bit better. Now I'm surprised that the orifice is probably right there at the bottom.
Mhm.
Push this one in. Okay, close, please. Close. Okay, just close. Keep closing. Is it snug? Good. Just cut it through, please. Good. All right. So let's see how this looks. So now I'm going to go back. We'll take this out. And now give me the hot biopsy forceps, please. And so let's take a look. So I think the margins are really good. Here's our AO, right? Look, there's the AO. See it?
Yes.
Smack in the middle.
Yeah.
Hey, let me push that little piece. Thank you. So the AO is still the lumen, I should say, to the appendix, right? Is still patent. And there's that little piece hanging on there. I think it's off, must be off, but I'll just pluck it off. And then Ray's going to tell me when the catheter is coming out, because if you don't know, it's always better to point down towards normal mucosa then if you jam it out, you're not going to end up perforating through something, right? Especially after you've already done resection. So, oh, good. Thank you, Ray.
And
All right,
Ken,
so now-
does this patient get a appendectomy sort of at this time, or you
Well, it
wait to see how
depends.
they
Oh,
symptomatic?
no, I don't think so. No, because there's nothing residual in there. I mean, I'll biopsy it. I always do, but I think we got it out completely. It's, it's about the optics. Okay, open. Of course, if you can then, so I need to just bring this up a little bit. I think this is off. It's floating nicely. Close, please, Ray. Okay. I just want to just see if it plucks off. See, it's really sort of off. Just look at that. Now
Dr.
it's off.
Binmoeller, again, thank you so much for this wonderful demonstration.